The gum elastic bougie was introduced into anaesthetic practice in 1949 by Sir Robert Mackintosh. Since that time, it's become an important adjunct in the management of difficult intubation by anaesthetists. If it were not for the bougie, many difficult intubations could not be accomplished without the use of more invasive techniques. This disposable instrument, known as the Portex disposable bougie, is a 70 centimetre long, 15 French flexible device with a coude distal tip. Immediately prior to insertion into the patient's mouth, the distal end of the bougie can be formed into a curve to aid identification and insertion into the trachea. After checking the laryngoscope, it should be gently introduced through the open mouth, and the laryngoscope blade aimed towards the right-hand corner of the mouth. Check that the lower lip is not caught between the teeth and the blade. It may be necessary to use a right-handed laryngoscope, whether a bad or capped teeth. Advance the tip of the laryngoscope blade towards the posterior pharyngeal wall, sweeping the tongue to the left in the process. Position the tip of the blade in the vallecula, glossoepiglottic fold, the area between the back of the tongue and the base of the epiglottis. Lift the laryngoscope upwards in line with the handle. This should lift the epiglottis upwards and expose the trachea and enable visualization of the vocal cords. In cases of a difficult airway, slightly curve the distal end of the bougie to aid insertion into the trachea. Confirmation of entry into the trachea is often obtained as the coude tip of the bougie bumps over the anterior wall of the trachea on the tracheal rings. Whilst maintaining position of the laryngoscope, the tracheal tube is passed over the bougie and advanced to a depth of 20 to 24 centimetres, while maintaining proximal control over the bougie and preventing it from advancing too far. Occasional rotation of the tube through 90 degrees will help it pass over the bougie and enter the trachea. Once the endotracheal tube is in situ, the laryngoscope and bougie are withdrawn. Correct placement is then confirmed by auscultation of the lungs to ensure mid-tracheal position.